Hello, everybody. Thank you very much for registering and attending this webinar today. My name is Andreina Mendez, and we're going to be talking to you about the autism with and without associated epilepsy care pathway in Europe. Firstly, I would like to thank the University of Cambridge Institute Trials Communication team for inviting me to prepare this webinar, and to Roderik, Plas, and Pierre Violland for accepting to collaborate with me and to present today. It's important to address that the views expressed in this presentation are ours, building on work conducted jointly with a team of collaborators, and are not necessarily those of the research founders. For any questions or any comments you may have regarding this project, please email me, and contact details are below. This study was sponsored by the European Brain Council, and it was a part of the Volume of Treatment Study 2, Round 2. For more information about the European Brain Council and the Value of Treatment study, you could go to the link below. But it's important to say that the EBC focuses on innovative research with the aim to converge data into policy recommendations. This study and some of the researchers, clinicians, and the autism representative that took part of the study are members of the Institute Trials Consortium, and some of them received funding from the Institute Trials Consortium as well. The Institute Trials Consortium for Package 5 Autism Policies Package objectives are to carry out high-quality policy-relevant research with autistic people and carers, to engage with autistic people and families throughout the project and communicate research outcomes with the community, and to communicate these research findings to policymakers to help develop policies and implement policies that support autistic people and their families. They are still conducting a survey called the 10 Points of Change Survey, exploring the policy priorities for autistic people and their families. So if you would like to collaborate and complete the survey, you could go to the link below. The Value of Treatment study follow a three-step approach that was suggested by the European Brain Council. The step one was to conduct a care pathway analysis in order to identify the unmet needs or treatment gaps of autistic children or their families and their possible causing factors. A care pathway is a multidisciplinary management tool based on the healthcare plan for a specific group in which the different tasks by the professionals involved in their care are defined, optimized, and sequenced. The aim of a care pathway is to enhance quality of care by promoting people's safety, increasing their satisfaction with services, and optimizing the use of resources. In the ideal care pathway, each person suspected of being autistic should have a screening visit, which usually is carried out by a pediatrician in Italy and Spain, or by a health visitor in the UK. If this screening visit suggests autism, a more comprehensive assessment called an autism diagnostic assessment should follow. And if the person is found to be autistic, personalized support, what used to be called or is known as intervention, should start soon after the diagnosis. The step two was to conduct an economic evaluation study. This is outside the scope of this talk. If you're interested in this information, you can keep an eye on Michela Tinelli's papers that have been, two papers that have been accepted for publication. And the step three was to propose policy recommendations on how to improve European care pathway. And I'm also happy to tell you that we got two papers that have been accepted for publication for European psychiatry, and one of them is already available online on the care pathway of autistic children with associated epilepsy in Europe. The care pathway and economic model analysis conducted in this study will inform policy harmonization in Europe with the aim of improving diagnosis process, personalized support, waiting times, and effective early treatment of epilepsy, therefore improving family quality of life. In order to conduct the care pathway analysis, we prepared a survey that was aimed at carers for autistic children aged 0 to 18 living in Italy, Spain, and the UK. This survey was developed based on the one conducted by the ASDEU study with a focus on the defined critical points that were decided by the working group, such as delays in screening and diagnosis, personalized support, and delays in the screening, diagnosis, and effective treatment of epilepsy. We form a working group, which members from the European Society for Child and Adolescent Psychiatry, representative and advocates from Gamian, EUFAMI, members of the autism community like Pierre and Roderik, members of Autistica, Autism Europe, members of the academia, and representative from institutions like the London School of Economics and Political Science, King's College London, Universidad Complutense de Madrid, Universidad de Siena, Universidad de Salamanca, Spanish and Belgium research councils, and representatives of pharmaceutical industry from Roche and Servier. And the members of the working group met twice in Brussels in person, and then we met remotely regularly due to COVID-19 pandemic between 2019 and 2021 to discuss and prepare the survey, discuss the results, define the critical points that we use in the survey, and to propose policy recommendations. We had a total of 712 people intended to complete the survey, but we had a total of 663 people who made the inclusion criteria. 547 completed the survey and 110 completed some of the survey. Our inclusion criteria was being a parent of an autistic child younger than 18 years old and a resident in the UK, Italy, and Spain. The age of the respondents in years was on average 44 years. The sex of the person completing the survey was mostly females, 84% of them. The autistic child's age at the time of the survey was on average 10 years, and the sex of the autistic child was mostly males, 77% of them. Here you can see the specific information on the child gender per country of residency. The identified treatment gaps we found were a delay autism screening diagnosis, a delay in autism screening and diagnosis. We observed that 49% of carers in the UK, 22% in Spain, and 15% in Italy stated it took them over a year after the first worries were raised to be offered a screening visit. And then about 68% of carers in the UK, 42% in Spain, and 22% in Italy reported it took them over a year after a screening visit to have a formal diagnosis assessment. You can see here that also a fifth of the UK sample stated that it took them over than 36 months in having a screening visit after reporting their first worries. And about a quarter of this population in the UK stated that it took them also over 36 months from the time they had a screening visit to have a diagnosis assessment. And it's important to remind you that the United Kingdom National Institute of Health and Care Excellence guidelines on the screening and diagnosis of autism in under 19 years olds states that if a screening visit indicates autism, a diagnostic assessment should start within 3 months. We also found an overall dissatisfaction with waiting times. 53% of responding in the UK, 50% in Spain, and 15% in Italy rated the waiting time from first worries until screening visit as inadequate. 48% of respondents in Spain, 47% in the UK, and 8% in Italy rated the waiting times for screening, from screening until diagnostic visit, as inadequate. We also found that no access to personalized support once diagnosis has been confirmed. Only 30% of respondents in the UK stated that the autistic children received any personalized support after diagnosis, compared with 80% in Italy and 82% in Spain. However, a good proportion of this high percentage in Italy and Spain rely on private funding or a combination of both private and public funding. So in here, you can see the public funding, the mere public funding in the UK was 20%, in Italy 42%, and in Spain only 22%. We also found a delayed access to personalized support, known as intervention, but we decided to change this term as it sounds quite surgical, so we changed it to, and that's why we're using personalized support after the T agreed to use it. So there was a delayed access to personalized support once diagnosis has been confirmed. Only 24% of respondents in Spain, 22% in the UK, and 19% in Italy said the time from a confirmed diagnosis until publicly funded personalized support started was less than 1 month, while about double, like 44% in Italy, 38% in the UK, and 30% in Spain said that it took them less than a month to start private funded personalized support. In here, you can also see that the time from confirmed diagnosis until access to personalized support is not as long as the time from first worries or first concerns until screening and diagnosis visit. Therefore, we feel like the delays in the access to personalized support is caused by the delays in access to screening and diagnosis. We also found an overall dissatisfaction with waiting times for publicly funded personalized support. 58% of respondents in the UK, 47% in Spain, and 34% in Italy rated the waiting times from diagnosis until publicly funded support started as inadequate. On the contrary, 87% of respondents in Italy, 71% in Spain, and 25% in the UK rated the waiting time for diagnosis until privately funded support as adequate. This is not surprising, of course. We also found limited information about autism and how to access early detection services. 52% of carers reported that it was not easy to access information about early detection services. And in here, we have to also point out that 40% of the responders, at least one member of the household had a university degree, and 26% of them, at least one member of the household had a postgraduate degree. Also, parents or family members, we noticed that parents or family members were the first to notice something different in the child's development or behavior, with 70% of the first worries being raised by them, as 19% were raised by a school or nursery or teacher member of staff, and only 6% were raised by a public doctor or a nurse, or a private doctor or a nurse. And the average age when they reported these worries was between 12 and 18 months of age. We also found an overall lack of support to parents' cares of autistic children. 41% of carers reported receiving no guidance on support after raising their first worries to their assigned professional. 31% of carers said they received very little or no support after the diagnosis was confirmed. 58% of carers said they had not received any training, coaching, or counseling to help them cope with their children's difficulties. And as we all know, raising an autistic child is quite stressful, and parents of autistic children report high levels of stress. And there is evidence of that. These are some of the quotations from the survey. So some of them say, no one from health services mentioned a possibility of autism until my child was 11 years old. Health professionals are not trained in autism. There are not enough diagnostic clinic services. Never received any early intervention program. Early intervention is crucial. I was given minimal information after the diagnosis. In conclusion, the identified treatment gaps in the care pathway may be caused by insufficient availability of public funded autism specialty clinics and autism trained specialists. Our results highlight the fact that publicly funded diagnostic and therapeutic services are unable to accommodate to a growing population and their needs. This results in long waiting lists or the necessity to rely on privately funded services. Despite autism's known societal and personal impact, Europe-wide consensus and support for early detection, diagnosis, and intervention are lacking. These findings call for policy harmonization in Europe to shorten the long waiting times for diagnosis and personalized support, and therefore improve autistic people and their families' journey experience and quality of life. Now, Pierre will talk to you about the autism and associated epilepsy care pathway in Europe. Thank you.
Thank you, Andreina. We will begin with a few facts about epilepsy in autism. While the prevalence of epilepsy in the general population is estimated to 1%, it reaches 21% in autistic people with intellectual disability. For autistic people without ID, it starts at 8% in childhood to rise to 19% in adulthood. In parallel, seizures in the context of autism may be more difficult to spot as their clinical presentation are sometimes atypical or can be confused with repetitive body movement and other behavioral features of autism. This means that epilepsy, while being a common occurrence in autism, can go unnoticed in many circumstances. Despite this, there is no consensus about electroencephalography assessment of epilepsy, when and how frequently it should be used, although this is a tool of choice to investigate. And for instance, clinical guidelines do not recommend EEGs as a screening tool, apart from specific cases. Now let's have a look into the study itself. Based on the same sample in Italy, Spain, and UK as the Autism Care Pathway study, we had a total of 552 included answers, in which 10% stated a diagnostic of epilepsy. The analysis of these answers showed the following treatment gaps. First, there is a large discrepancy about the professional involved in the epilepsy diagnostic process. As we can see, the involvement of a child neurologist during the process ranges from 4% in the UK up to 74% in Italy. These results highlight the lack of a consensus regarding the medical specialist who should evaluate children for the presence of co-occurrences and, for instance, epilepsy during the autism diagnostic process. In the same way, the methods used to diagnose epilepsy are not consensual. As we can see, there is also a large difference between countries as to whether an EEG was done to investigate for epilepsy. But we can see on the right-hand side graph that EEG is almost the only way which ended up into an epilepsy diagnosis in the sample. This raises the question about the pertinence and the cost-effectiveness of a systematic screening of epilepsy by a specialist. We did not find any consensus on this matter, and we have not found either any relevant studies to evaluate this cost-effectiveness. When epilepsy is diagnosed, we also found country specificities on the treatment. When 100% of respondents in Italy reported that they were prescribed anti-epileptic drugs, Spain and UK show significantly lower figures, although NICE guidance for epilepsy, for example, clearly states that epilepsy should be treated early. Another point in this guidance is to avoid treatment with multiple drugs. Monotherapy should be the norm, although drugs can be changed in the case of lack of effectiveness. In this graph, we can see that monotherapy is not the rule in Spain. At the end of this study, we can clearly see the effect of absence of a harmonized European clinical guideline specific to the assessment and management of epilepsy in the context of autism. For example, NICE provides separate guidelines for autism and for epilepsy. ESCAP developed practice guidance for autism. But as far as we know, there is nothing that covers the specifics of epilepsy as a co-occurrence of autism despite its frequency. This lack is obvious when we see the heterogeneity of results across the 3 countries that we have studied, and it implies that caregivers must make great efforts to reach a timely screening, diagnosis, and adequate management of epilepsy in autistic children. When it comes to the care pathway, there is no consensus on who should do the investigation as seen in the results. And as mentioned, research on the cost effectiveness of a systematic epilepsy screening after an autism diagnostic, this research would be extremely beneficial. Also, what we know of the treatment in epilepsy is not specific to autism, and we believe that the absence of autism-specific studies of epilepsy treatment is an issue. So, in conclusion, this study highlights the need for Europe-wide policy harmonization in order to improve the experience and quality of life of autistic people and their families. This policy shift needs to be triggered by the development of harmonized evidence-based clinical guidelines, which should be a clinical and research priority in Europe, given the frequency of epilepsy in the autistic population. And now, Roderik will talk about our working group proposed policy recommendation.
Yes, thank you very much, Pierre, for giving me the turn. Now we'll head to our autism policy recommendations. Very important is to raise awareness among parents, family members, the community and primary care providers about developmental milestones, the early signs of autism, and the importance of early detection and early support. We should encourage professionals to listen to family worries and address them immediately. Increase autism-specific triage programs at well baby clinics. In other countries, they are called differently. They are, for example, in the Netherlands, they're called consultation bureaus or consultation agencies, where a healthcare worker usually does the visits with parents at their homes, or at their homes, or well, it depends, but at their homes. So, provide autism training to first-line health services professionals. Reduce the delay in screening and diagnosis, thus enabling children to begin personalized support programs earlier. Increase support to families of children diagnosed with autism. The development of evidence-based personalized support for autistic people and their families must be considered a key research and clinical priority. Then we have recommendations for autism with epilepsy policy. Well, policy recommendations for autism with epilepsy. Inform health workers and carers of autistic children for the frequent co-occurrence of autism and epilepsy. Provide information on seizures characteristics in autistic individuals and basic life support to carers of autistic children. Provide training on seizures characteristics or clinical presentation in autistic individuals to neurologists. Refer the autistic child to an epilepsy specialist for timely screening, diagnosis and treatment of associated epilepsy. And if epilepsy is suspected, an EEG should be done. It should be done. Avoid the use of multiple anti-epileptic drugs in autistic children. However, the choice of treatment should be made by the specialist in agreement with carers. Monitor autistic children with epilepsy in a clinical setting at least twice a year. Develop harmonized, evidence-based clinical guidelines specific to the assessment and management of epilepsy associated with autism must be considered a clinical and research priority in Europe. Autism, epilepsy, and members of the autistic community should be involved. For policymakers to consider, it's really important to invest in educating and training the future mental health care professionals, because fewer teachers means fewer mental health care professionals, which in turn causes long waiting lists and just a poor quality of life for many people. Keep mental health professionals working in health services. Trained professionals have to leave mental health services due to increased possible demands put on them that affect their own mental health. So people are then leaving. We shouldn't have that. We shouldn't want that. We need more autistic mental health care professionals who better understand autism and think in the spectrum. Reassess the education system. Prepare autistic children for life events, life phases, etc. And not just autistic children. This is a general recommendation for everyone, because we all need to understand what's going on in our lives and in our phases, in these phases, and that will also benefit autistic children after all. Respect the human rights of autistic people. Current denial of person. So what it says here is there is a tendency to not see us as human beings. There is a tendency to see us as objects of research or objects of diagnosis, treatment, etc. So you need us, no, we need you to value us as individuals, and we have our value and place in research and all kinds of consultation. Assess autistic people's needs and reassess them during critical life transition periods. Such as teenagehood, such as the transition from a teenager to becoming an adult. Those very important transitions that are very difficult for many of us, but they are even more difficult for autistic people. And autistics will need to have the support so they can understand what is going on, what is expected of them, and what they can do, what they're able to do also. And we need to be mindful that we, in Europe, or most of us, live in a knowledge economy. Parents need to be careful about the demands they put on their children. When you have loads and loads of things to do and loads of demands, loads of expectations to live up, that will cause a lot of stress. And if you fail to live up to these expectations, that will be another traumatic experience, which in turn hampers much of our development. And finally, reduce the economic inequality that is in our countries. in our societies. Then I'd like to give, or we'd like to give our special thanks to our sponsors. We'd like to thank the European Brain Council, AIMS2 Trials, Roche, Servier, and all the carers that completed our survey. The ASDU team, UCAM team, especially Molly McCabe and Rosie Holt, and all members of the working group, which was led by Professor Celso Arango. And I must really thank you. Thank you very much. And I'm very glad that you attended this presentation. And we'll now go to our questions. Thank you.